myelodysplastic syndromes, or MDS, represent a heterogeneous group of clonal hematopoietic stem cell diseases with varied clinical presentation, morphologic features, prognosis, and variable risk of leukemia transformation. The common features among these disorders is ineffective production of normal mature blood cells with one or more peripheral cytopenias or deficits in blood production. More advanced disease is associated with progressive bone marrow dysfunction or bone marrow failure. The average age diagnosis of MDS is in the 8th decade of life. MDS remains an incurable malignancy for most patients. However, for those patients that have a compatible donor and are appropriate candidates, allogeneic stem cell transplant represents a potential cure. The leading cause of death is the disease itself, primarily infection. Risk-stratified treatment strategies are key to the best treatment outcomes. The initial patient evaluation most often includes a complete blood cell count, which reveals the normocytic or macrocytic anemia, normal to decreased neutrophils, and variable platelet counts. Anemia is observed in 90% of patients with MDS, either at initial presentation or during the course of their disease. A careful history and additional laboratory analysis should be pursued to exclude other causes of cytopenias, such as vitamin B12 or folate deficiency. Baseline serum erythropoietin levels are critical to evaluate the role of erythropoietin-stimulating proteins. We classify the type of MDS and the severity of disease based upon two classification systems. One is the morphology, or the appearance of the cells under the microscope. These include two systems, the French-American-British Classification System, or FAB, and the World Health Organization, or WHO Classification System. To determine the prognosis, we evaluate disease-related features associated with risk. To do this, we use the International Prognostic Scoring System, or IPSS, and more recently the revised IPSS, or what we call the IPSS-R. These evaluate the number of blasts in the bone marrow, the number of cytopenias in the peripheral blood, and specific chromosome abnormalities. The International Prognostic Scoring System was developed to reliably estimate survival and the risk of transformation to acute myeloid leukemia in the absence of active treatment. The IPSS assigns a score based on the percentage of blasts in the bone marrow, the initial chromosome abnormalities, and the number of cytopenias or lineages that are affected in the peripheral blood. Karyotype or chromosome abnormalities are considered to be good if they are normal, if there's loss of the Y chromosome in men, if there is a chromosome 5q deletion, or a deletion of chromosome 20q. Whereas intermediate karyotype would include other abnormalities. Complex chromosome changes, meaning 3 or more abnormalities, or chromosome 7 abnormalities, are considered to be poor risk chromosome abnormalities. The severity of cytopenias that are used for defining IPSS scores are a hemoglobin less than 10, an absolute neutrophil count less than 1,800, and a platelet count less than 100,000. IPSS risk stratification is a critical component of treatment selection with consideration for the goals of therapy. In low-risk disease, that goal is improving hematopoiesis or peripheral blood count improvement. And in high-risk disease, the goal is to extend survival. The revised IPSS or IPSS-R includes many of the elements of the original IPSS. That is, cytogenetic abnormalities, the percentage of blasts in the bone marrow, but it also considers the severity of the cytopenias for each individual deficit, that is, hemoglobin, platelet count, and neutrophil count. Each of these are assigned a score, allowing them to stratify the disease into 5 different risk categories. One is very low risk with a score of 0 to 2, good risk with a score greater than 2 to 3.5, intermediate risk with a score greater than 3.5 to 5, high risk with a score greater than 5 to as high as 6, and finally very high risk disease with a score that's greater than 6. The goals of therapy for patients with MDS are based on the individualized disease characteristics, the patient's features, as well as the risk category. transfusion dependence, or progressive or symptomatic cytopenias generally indicate the need for active therapy. For patients with low-risk disease, the goal is simply to improve hematopoiesis, improve the quality of life, and minimize toxicity. Extending overall survival has been demonstrated in one study using azacitidine. In high-risk disease, the goal is to extend survival and suppress the potential to go on to acute leukemia. These patients are at high risk for early transformation to AML and generally require immediate and aggressive therapy. De novo MDS, meaning arising without any prior treatment or other abnormalities, is associated with a more favorable outcome when compared to treatment-induced, or what we call secondary MDS, which is associated with a poor response to standard therapies. Red blood cell transfusion dependence is associated with a more inferior outcome in patients with MDS compared to those that are not receiving regular red cell transfusions. This may, in part, relate to the fact that this is a higher risk feature. And despite otherwise lower risk disease, it translates into a reduced survival and greater risk of AML. However, it may also be because of transfusional hemosiderosis, or iron overload. Each unit of blood has 250 milligrams of iron, and our bodies do not have a good way of getting rid of iron. This has led to interest in chelation of iron. The current treatment alternatives for patients with lower risk disease focus on supportive care or improving hematopoiesis. In supportive care, we consider red blood cell transfusions for symptomatic anemia, erythropoietin-stimulating agents, or what we call ESAs, that include agents such as Procrit and Aranesp, white blood cell growth factors that stimulate neutrophil production, antibiotics and treatment of other common illnesses, as well as iron chelation therapy. For active therapy, treatments such as Revlimid or lenalidomide that were approved in 2005 for the treatment of a specific subtype of MDS with chromosome 5q deletion. Also, we have immunosuppressive therapy, and even the azonucleosides or hypomethylating agents can be used. For all other patients, and particularly those that have failed standard therapies, we consider investigational agents or clinical trials. The erythropoietin-stimulating agents, or ESAs, are still the most commonly prescribed drugs for the treatment of MDS. But this is not an FDA-approved indication. They are approved for other indications. However, they are supported by guidelines, including those of the National Comprehensive Cancer Network. In a survey that was conducted several years ago, more than half of the patients with MDS had used ESAs. The FDA's what we call REMS program was started in approximately 2009 but does not apply to patients with MDS. The FDA, I'm told, just ignores these data points because it's an off-label indication. The response rate to treatment with erythropoietin, or the ESAs, is much lower in patients with MDS than it is in patients with other malignancies. The average response rate ranges from 15 to 20%. However, there are certain features that identify patients with a more favorable response. Those include a serum erythropoietin level that is less than 500, subtypes of MDS other than refractory anemia with ring sideroblasts, and the lack of need for frequent transfusions. The response rates to ESAs can be improved when given in combination with other growth factors such as G-CSF or Neupogen. The Nordic MDS group developed a predictive model to identify those patients who are most likely to benefit from treatment with an ESA. This includes a lower serum erythropoietin level and a lower need for red cell transfusions. Specifically, less than 2 units of red blood cells per month. In the absence of a heavy transfusion needs and a serum erythropoietin level less than 100, the probability of response to an ESA, either alone or in combination with Neupogen, is estimated around 70 to 75%, whereas in the absence of either of these variables, the response rate is poor and is less than 10%. A retrospective study that was done using 3 Nordic group trials and comparing these results to patients that had similar features in a database in Italy showed that treatment with erythropoietin improved survival in those patients who responded. there is no difference in the frequency of transformation to acute myeloid leukemia. Lenalidomide, or Revlimid, was approved for the treatment of chromosome 5q deletion MDS in 2005. This began with an exploratory study to determine the best dose in the MDS-001 trial. The registration trial included 2 multi-center studies. The MDS-003 trial included only patients with lower risk MDS that had the chromosome 5q deletion. All patients were transfusion dependent, and all patients had a platelet count greater than 50,000 and a neutrophil count greater than 500. In the companion study, the MDS-002 trial, all other patients with similar features but without a chromosome 5q deletion were enrolled. In the MDS-003 trial, or the chromosome 5q deletion study, more than 2/3 of patients became transfusion independent, with a rise in hemoglobin that was nearly normal. Median duration of response was lengthy, averaging over 2 years. And overall, 70% of patients had a cytogenetic response and 45% had a complete cytogenetic response, meaning the chromosome abnormality could no longer be detected. In the MDS-002 trial, that is, those patients without chromosome 5q deletion, only 26% of patients achieved transfusion independence, for a much shorter duration of only an average of 41 weeks, and only 9% achieved a complete cytogenetic response. When lenalidomide was approved by the FDA in 2005, they recommended that a second trial be performed to identify a potentially lower dose that may be equally effective. That led to the MDS-004 trial. This was a randomized phase 3 placebo-controlled study evaluating 2 doses of lenalidomide. This included 10 milligrams for 21 days or continuously for 28 days, which is the approved dose in the United States, or lenalidomide at 5 milligrams daily for a 28-day cycle. Finally, a third arm received placebo. Patients received blinded treatment, meaning the investigator nor the patient understood what treatment they were receiving for the initial 16 weeks. For patients who responded to treatment, they remained on treatment for up to 1 year. For patients who did not respond in the placebo arm, they could receive treatment with lenalidomide. The primary endpoint of the trial was transfusion independence for greater than 6 months. The results of this trial show that the 10 milligram dose of lenalidomide is superior. The 10 milligram dose of lenalidomide proved to be the superior dose for patients with deletion 5q. On the right-hand side of the screen, you can see for those patients that had a confirmed diagnosis of lower risk MDS, the overall frequency of transfusion independence was 61%, compared to 51% in those patients receiving the 5 milligram dose, and 7.8% in those patients receiving placebo. If we look at those patients who achieved transfusion independence for over 26 weeks, 56% achieved durable transfusion independence with the 10 milligram dose, compared to 42.6% with the 5 milligram dose. The average rise in hemoglobin was best with 10 milligrams of lenalidomide, reaching 6.3 grams for patients with that dose compared to 5.1 grams for patients with lenalidomide at 5 milligrams daily. In conclusion, treatment selection for patients with MDS is guided by not just the diagnostic category, but also the risk category based upon the IPSS stratification system. Growth factors are very effective for selected patients with lower risk MDS, but safety still has not been proven in a randomized phase 3 study. Transfusion independence, we now know, remains a desired patient outcome that may improve overall survival. An improvement in survival and suppression of leukemia may be achieved with disease-modifying agents and effective management of disease and treatment-related side effects. Iron chelation can improve the amount of iron and decrease iron stores, but is unclear if it leads to patient outcomes that are improved, such as improvement in survival and lower risk of leukemia. Lenalidomide remains the treatment of choice for those patients that have a chromosome 5q deletion and lower risk MDS with red blood cell transfusion dependence. Thank you for joining me in this review of lower risk MDS. For any additional information, please contact the MDS Foundation or go to their website at www.mds-foundation.org.